Good evening to all of you. At the outset, allow me to thank Jodhdev sir and his team at JPEF for giving me the opportunity to chair a very important session on NCDs, non-communicable disease. It's also a double pleasure because I am chairing a session which is being done by one of the doyens of diabetes in India, A.K. Das sir. So NCDs, simply put, are defined as diseases having long duration and which are generally slow in progression. And it is definitely the leading cause of death in the world, accounting for about 63% of all mortality in the world. If you take the Indian statistic, it is around 53%. More than 50% of deaths in India produced by NCDs. And if you take the breakup, the leading cause of among the NCDs is cardiovascular disease, which accounts for 24% of all deaths in India. COPD and other respiratory diseases account for 11%, cancer around 6%, and diabetes accounts for 2% of all deaths in India. So which are these NCDs? Because previously the focus was on all these communicable diseases, those produced by infections, viruses, bacteria, but most of them have been brought under control by vaccines and other antibiotics and other preventive measures. But now it's the age of the lifestyle disease and non-communicable disease, which includes diabetes, hypertension, obesity, cardiovascular disease, stroke, cancers, mental illness, injuries, road traffic accidents, etc., etc. So the Indian government has come up with a lot of national programs, just like we had National Leprosy Eradication Program, National Filaria Eradication Program. There are so many national programs for the NCDs also. Among this, the most important would be National Cancer Control Program, National Tobacco Control Program, and one of the most important relating to the lifestyle diseases, NPCDCS, which means National Program for the Prevention and Control of Cancer, Diabetes, and Stroke. To develop on all these and much more, I invite the most eminent speaker, A.K. Das sir, who is a professor of medicine and technology at Puducherry, past president of AP and RSSDI, currently dean and director of JPMA, Puducherry. Over to you, sir.
Esteemed chairperson, thank you very much for this erudite introduction that you gave. I have got 16 minutes, so I'll be very fast. So I'll be a little fast, but I will not omit any important issues. Now I'm talking about, as Professor Harikrishnan pointed out, the national preparedness for meeting the challenges of the NCD. The talk plan includes the burden of diabetes and other comorbid conditions. I will allude to ICMR in-depth study. Ranjit is just outside gone. He is one of the author of this study. I'll talk about the young diabetes registry, CDIC changing diabetes in children in India, and the national control program which chairman alluded to. So I'll go to the ICMR in-depth study, of which I'm very happy Ranjit is here amidst us, one of the co-investigators and the very much involved in that particular study. Dear friends, as it said here, I think I'll omit this to say, suffice to mention that NCDs today, all the things chairman has already alluded to, is most important component of the morbidity and mortality in our country. And if you deal with NCDs, it's a lot of money. Therefore, we have to take care of the NCDs. Government has realized that. We have also realized that if you have to sustain human development, the NCDs, both its social component, economic component, and environment component play a very important role. And as the age advances, we have more and more of NCDs, and these four NCDs, CVD, respiratory disease, diabetes, and cancer, are responsible for more than half of the deaths in India because of these diseases. Now, I will not allude to injuries and other things for lack of time, not go to the major burden, but suffice to mention that it is IDF 2011 data. Out of every 3 seconds, now it is 2 seconds, one person dies with diabetes, and one person dies with the complete diabetes every 2 seconds in the globally anywhere, and you will find that a limb is lost every 25 seconds. And therefore, we will go directly to the government program, the ICMR in-depth study. This is one of the flagship program of the government of India to contain diabetes. The primary objective determine the national prevalence of diabetes and the pre-diabetes, and it is a cross-sectional door-to-door survey. And I was alluding to that this study is pioneered by Professor Mohan, who is the PI, and we have the others, the Anjana, Ranjit, who is present here, and the Dr. Pradeepa, who are the other drivers of the study, and I am one of the steering committee members. Now, lack of time, I won't go details, but suffice to mention, it's a pan-Indian study and both rural and urban study. That's the beauty of it. And it is absolutely foolproof study, gone through the census, how do we identify the houses to study, it's a house-to-house study. The data from these 3 states and 1 UT was published first, and the publications is here. Anjana is the first author, where it showed, depending on which we found out that the 69 million is the prevalence today and the pre-diabetes. Now, if you see here, the urban and the rural prevalence of diabetes in Tamil Nadu, Chandigarh, Maharashtra and Jharkhand, you found that Maharashtra was 11%, others were around 13 to 14%. Now, therefore, from this study, that time, 11, we said about 63 million people are diabetics, and we also found the urban-rural divide, and we found the self-reported cases, the newly diagnosed cases, meaning thereby the screening is a very important component to find out diabetes mellitus. A lot of undiagnosed diabetes still in many parts of India. I will omit this because of lack of time again. And also one of the important facts that I would like to put before you, that diabetes today is moving towards younger age group. I'll show in a minute how that is significant. The glycemic control is abnormally low. You'll find the majority of the people are very poor control, and the management, you see, self-reported management is also not satisfactory. Now, coming to the prevalence of pre-diabetes, which is a major concern, which can be prevented by simple diet and physical activity, is also widely prevalent, and you find that about 12 to 13% people are in the pre-diabetic stage, and this should be the target to prevent them becoming diabetic. Now, extrapolating the data, we found about 77 million people in India have pre-diabetes. So obviously the epidemic is not yet over and going to multiply further. Now, it was also appalling to find national study that the physical activity is abnormally low. The sedentary activity, you can see the males and females between 71%, and it is very appalling. There is a lot of physical inactivity. Now, the dietary characteristics also, we found that pan-Indian, lot of wrong diet being taken, the energy-rich food, and also you find that even the leisure time physical activity is much less, meaning thereby it is almost certainly very predominantly inactive population. Now, if you find the effect of heritability, which is India is a very large country, lot of heritability, the heritability and physical inactivity together probably responsible for this wide epidemic of diabetes in our country. Now, coming to knowledge and awareness of diabetes in urban-rural Indian population, just published data from our study, you will find that the people know that they're diabetic, but you know there's a number of people also know that they're not diabetic. We found that 50% of the people in the 4 regions of India had a condition called diabetes, half of them. A significant disparity exists in the level of knowledge of diabetes between different regions. We found in South India it was much better, but Northern India it was not so. In rural areas, the awareness and knowledge of diabetes mellitus was significantly lower, and females had low awareness rates compared to the males. So there is a lot of work to be done in this field, and also it was found because of lack of awareness, the rule of 50s, almost 50% people of diabetes are undiagnosed. I just omit this to go to the main part. Now, it was also observed in this study that the hypertension was also widely prevalent. We have data on the hypertension and hypercholesterolemia. You will find that the self-reported hypertension and newly detected hypertension was quite a bit. You find, to take any state, it was almost double of diabetes. The hypertension in the urban population varied between 24 and 31 in either sex, meaning thereby that hypertension is more prevalent and that needs a lot of attention. Now, if you come to this lipidemia, I'll go to the summary slide. We found that if you take the 4 regions, at least one lipid abnormality was presented in 80% cases. That means dyslipidemia was quite rampant, and various states at various levels of dyslipidemia. And about the strokes, it was seen that we didn't have a pakka data for the stroke, but the strokes in earlier studies, in I7 in-depth study, stroke was not included. So I have brought this from the neuroepidemiology study done some time back. The prevalence stroke in the younger age group was quite sizable, and of all the strokes, 18% were young. I'll not go into the T2 diabetes and stroke. I'll just go to the study, which is this data which I'm presenting is not published data. I'll go to the major one. You will find in the 13 states that the study was completed by the time this PowerPoint was prepared, the prevalence varies between 5.8% to 15%. In Mizoram, the prevalence was lower because of a lot of physical activity and walking in the up and down the hills and the terrains, and you find that across India, the prevalence in the 13 states is between 6 and about 15%. And at this stage, I'll pass on to the second part of my talk. Now this is a study which I'll put before you, which is a Government of India study. This is a ICMR, Government of India ICMR, Young Diabetes Registry, which I chair. Now this study wanted to look into the classification and socio-demographic profile, the clinical profile, the complications, comorbidities, and the details of current treatment practices in the young diabetes. We took the diabetics where the onset was below 25 years of age, and we had about 16 centers. I will go to the summary slide because there is not time to present the whole thing. But we have robust data, and it has been also published as a report, and the main paper, one of the papers and published, sorry for this rushing through the slides, but I want to be in time. If the key take-home messages from the ICMR Young Diabetes Registry, there are more than 10 variants of youth onset diabetes in the registry, in which type 1 was the majority. That's 64%, followed by type 2 diabetes in the young is catching up, almost 26%. But I must also tell you that there was a divide. If you go to the corporate hospitals and the private diabetes care setups, the type 2 diabetes in the young was more because obese people. In contradistinction, in the civil hospitals, as expected, type 1 was more. We found the 50% type 1 diabetic patients registered within 6 months, and rest did not register. That possibly means they had some beta cell reserve, and of course not avoidable diabetes mellitus. Now about the type 2 diabetes in the children who are obese, we found that almost they took 3 years to come to the hospital, meaning thereby this is silent, just obesity. They are not known they are diabetic, so very useful time is lost. And it was also found that 1/3 of the youth onset type 2 diabetes was identified incidentally during the medical examination. So this is very important. The other issue that I would like to talk about is also we have another initiative in the country called CDIC, the Changing Diabetes in Children initiative, which again me and Prasanna chair. I'll go details of it. It's a study, which is a public-private partnership study with the Ministry of Health, Civil Society, WDF, Roche, ISPAD, and the Novo Nordisk. And we will find that this is rolled out in 2011 and 12. We have been almost 5 years through it now. Now, what are the program design? We are looking at a diabetes registry, which is monitoring and control, the development or the providing on the infrastructure and equipment, that is monitoring apparatus to the patients, and training of the healthcare providers. Free insulin. The number of children in this study are totally given free insulin lifelong. Now it is up to 21 years of age. We want to extend it to longer period. We give patient education and also ensure the cold chain supply of the insulin and also supply of the whatever pens or needles that they're using. Now we have enrolled about 11,000 children today under this globally. Out of this, India has got maximum. It's very gratifying. We have 4,044 children under this study. And what are the key impact? Reducing the children developing diabetic ketoacidosis, decrease in mortality, reduction in the number and duration of admission each ward. And I have no time, but all this has happened over 5 years. Reduction in number of school days lost for the children. Diabetes education has been a key to ensure compliance, and significant increase in body weight of this type 1 diabetes children. There are centers in the country. Today we have 23 centers from AIMS to down south to JPEF, and from the Nalini Sah's KM hospital to the PGMR in Calcutta, spread across the country, 23 centers, and these are the various baseline characteristics. I'll just come again to the summary slide to say that in the recent analysis we have found that the HbA1c has come down by 1, and also the other parameters have significantly improved. I will not go details of it, but this is important that we found some sites did better. 17 sites did better than the other 6 sites. The largest population had about more than 10 HbA1c, which has come down to 9. I will go to the next part and the last part of my presentation. I have 2 minutes left. Okay, last part of the study, I'd like to describe that we have launched a nationwide program called NC National Control Program for Diabetes, Cardiovascular Disease and Stroke. As Chairperson rightly pointed out, it is NCPDCS. Now this is a very comprehensive program. We have allotted for cancer 495 crores, and for the diabetes, hypertension, stroke and CVD 470 crores. As you rightly pointed out, sir, the cancer has got the maximum money. We have about total allotment is about little above 1,000 crores. Now the focus under this program are 3. Number 1, the school, community and the workplace. So we want to spread 3 messages. One is education, number 3, healthy practices, and third one is the eradication of the common soil risk factors. The common soil risk factors are primarily behavioral risk factor like tobacco, alcohol, physical inactivity, the disease risk factors like hyperglycemia, hypertension, and outcome risk factors like the people who have become very obese over the years and have become the partners in the epidemic of this NCDs. Dear friends, this my government focus today is on the NCDs, and we have spread this program. We have got universal screening of the program. We have screened about 4 crore people and provide the treatment, provide the diabetic specialist nurse in every CSCs, and I'm delighted to inform you that Kerala and Tamil Nadu are the states which have done best. We also provide doctors under a fee for service. If the PSC wants to take a cardiologist, ophthalmologist, they can recruit them, for which we'll pay. We pay 2,000 upfront, and for every patient beyond 4 patients, we pay 400 rupees. So dear friends, I hope this program will be fruitful, and NCDs will have a very dignified and very significant impact through this program. Thank you very much for the patient hearing.
Thank you, Das sir, for the lucid, comprehensive, exhaustive, but at the same time very disciplinarian presentation, because his eyes were always on the
work address the treatment. For example, how many were on OHA, how many were on insulin. So what is the general trend in India?
I must tell you that when we went through the analysis of the treatment pattern, we found that 59% were on the metformin, and about 30% extra were on the OHA alone. Sulfonylureas alone, or metformin sulfonylureas. The use of insulin total was 19%. 19%. That included what we call BITS therapy, bedtime insulin, daytime sulfonylurea, combination therapy. Insulin alone was about, as I told you, 11%, 100 minus 89. We have data for everything and is being published one by one. And of late, the insulin use is growing gradually high. But this is a study, COT study at 2012. Complications galore.
Retinopathy, diabetic nephropathy.
Matthew, I showed you the complications. If you take hypertension as such, it's almost double of diabetes. So 24% in the females and about 31% in the males.
How does it compare with the Western standard?
Westerners, the population, Western population, the prevalence of hypertension in diabetics is 40%. 40%. We have little less, 31% and 24%. And when the diabetes and hypertension both are combined, the nephropathy, the retinopathy and the cardiopathy is very, very huge. So we have data on the lipids, which I showed you. 80% had at least one lipid abnormality and many had multiple lipid abnormalities. And when combined together, we have not looked at the microalbuminuria, we have not looked at the ECGs. We have done ECGs 1 in every 5. And those have shown changes which has to be analyzed. We have not done ECG for all the population, but one in every, as a representative, 1 in every 5 population. Those have to be analyzed. But I believe with the combined diabetes hypertension, the microvascular complications will be great.
Insulin used?
I told you, sir, it's 11% alone. I'm talking type 2.
What insulin?
Sir, it is mostly the used insulin is NPH.
Sir, you were alluding to the young generation affected. Was there any focus on the MODI, LADA types of younger onset
I think this is a very, very pertinent question. Doctor, I'll pass on the published paper to you. We could find 10 varieties of childhood diabetes. Out of the 10 varieties, we had about type 1 diabetics, 63.9%. Because majority of the government centers were public and where the people go for the insulin, to be very frank with you. We had 2 centers. One is the center, example, one center of Chennai is Mohan Center, had more of type 2 diabetes in children, almost 40 type 2 diabetes children, only 60 requiring insulin. I'm sorry, the other way around, 60 type 2 diabetes in children, only 40, those children were coming for insulin. Similar thing was observed in Assam. They also had a little bit more of type 2 diabetes in the children. About the MODI, Government of India has established a center of genetic study of diabetes in Chennai. And we can send our samples. Now we found the type 3 MODI was the maximum prevalent. But if you ask me the exact prevalence, I won't be able to tell you because that analysis has not been done. But it is the other 8 varieties. We looked into neonatal diabetes, which can be related with sulfonylurea, MODI diabetes. We also looked into the various other things like with deafness and mitochondrial diabetes, very, very small percentage. But MODI, if I remember correctly, it was almost about 1%. And type 3 MODI was the highest. Yes, Bala?
What's the prevalence of type 1 diabetes in India? Actually, there is no, there are only 1 or 2 reports. One question, and one more question.
Yes.
Is there any program for giving insulins to deserving or poor type 1 diabetic patients in the national level?
We have worked together. I spent 3 years, we have worked together. The policy is like water, sunlight and air. Free insulin is birthright. I'll repeat again. We have already told this in many forums that like light, water and air, for type 1 diabetics, insulin is the birthright. Therefore, under the program, we provide the human insulin, BHI, either the human mixed-start, which is commonly used today. We saw all the new drugs, but common is BHI. The biphasic human insulin or the human mixed-start is maximum supplied, and we supply the free insulin. Now, under this program, we provide 4,040 students. My good friend Amal is here. He's from this state. Amal and their Life for a Child and all, they provide to 14,000 children. And government supplies the rest. But having said that, I'm acutely conscious there are some children who still die because of lack of insulin. Partly because they are not accessing the healthcare, but insulin is freely available. Am I correct, Matthew? Insulin is freely available. There are three models where they come to the hospital morning and take insulin. That is the Chennai model. 800 people come in the morning to the Kilpak Medical College to take insulin. JPEF model, we give them for a month. they have to bring back the empty bottles just to account for it, and they have not sold it, they have taken it. And the third model is that giving them money to buy insulin. But under the national program, insulin is freely available.
Regarding the prevalence of type 1
That's
diabetes.
a very significant question. The prevalence today is estimated is around 2% of the whole diabetics. And the rise is 3% per year. It is going to become a huge problem.